Welcome, everybody. Welcome, everybody. Thanks for joining our panel. This is an interdisciplinary panel on artificial intelligence and discrimination risks in the health sector, sometimes abbreviated to AI. I have the honor of moderating. I am Frederik Borgesius, a law professor in the Netherlands, where I teach law to computer scientists. I work in a computer science department. And we have, as I said, an interdisciplinary panel with different expertise. And I'm going to briefly say a few words about each panelist, and then I'm going to ask each panelist whether from their own background they have any particular thoughts about AI and discrimination risks in the health sector. No, I'm going to give you one example. I assume that most of the audience members have heard about the risks that artificial intelligence can discriminate, for instance, in the context of policing. In the health sector, you could imagine, for instance, let's say that you train an AI system to recognize skin cancer on pictures of people's skin. If you would train such a system only on pictures of white people's skin, there may be a risk that the AI system becomes very good at recognizing skin cancer on pictures of white people, but that the system performs worse on pictures of people with a darker skin. So that is one example of how, at least in theory, the use of AI in the health sector could have unwanted discriminatory effects. Oh, by the way, we will not present you with PowerPoint slides. It's gonna be a discussion panel among the panel members, and please feel free to ask questions in the chat, audience members, and then I'll also incorporate them into our discussions. And panel members, please realize that I'll also do my best that we have audience from many different disciplines. So, for instance, I'm a lawyer, but I'll try not to talk in Article 8 of the European Convention on Human Rights, and let's all try to stay away from abbreviations, etc. Minna, Ruckenstein, could you say a bit about yourself and whether from your background you have any particular thoughts or worries in the context of AI in the health sector?
Yeah, thank you, Frederik. So I lead an interdisciplinary research group at the University of Helsinki, and we explore with ADM and artificial intelligence cases, like empirical cases, but also in other areas. So ADM and AI in health, you probably all know that it's a very busy area. So there's a lot of exploration going on and lots of different models. And my voice is really like there's some background noise. Maybe
sounds good for us.
We have to. Okay, so I have a lot of background noise. So, but you can hear me.
For us, you sound good.
Okay, sorry, I get distracted because there's just like too much noise going on. So ADM and AI in health is a very busy area. So there's a lot of things being explored and pitched. And for us, I think the fundamental question is like whether we are talking about something that is pitched and not actually out there yet. So whether it's a machine learning model or whether that model is already being implemented. And once it's being implemented, those are the questions that we are interested in, because then these models, they need to be adjusted, they need to be developed. If something goes on, they need to be repaired. Somebody's evaluating them. And I think that these questions are really interesting. And then ultimately, the organizational environment and the decision-making system or AI system, those kind of determine whether that overall system can be just and ethically robust. So it's not the technology per se that we are looking at. So what I think I will be bringing to this panel is kind of this down-to-earth perspective rooted in practices, socio-technical rather than technical.
Thank you. And how could you summarize what is your disciplinary background?
I was trained as a cultural anthropologist, but I have to say that I've drifted some way from there. So now I'm working with economic sociologists, science and technology studies people, some data analytics people. So it's a very kind of depends on the project that we are doing. But for me, it's very important to be in dialogue with technology developers and also the people who are using these systems. So in lots of our project, we have the stakeholders also very much involved with the actual research that we're doing.
Thank you very much. Then I'll move to Tena, the Deputy Ombudswoman of Croatia and the chair of the executive board of Equinet, that is the European network of equality bodies. And since this is mostly a privacy conference for the privacy people, that means Equinet is comparable to the role of the European Data Protection Board in data protection law. So it's kind of the cooperation body of all the non-discrimination authorities in Europe.
Yes, well, thank you, Frederik. I'll tell you what I do and how it's connected to the topic. So I'm the Deputy Ombudswoman in Croatia, which means I work at a institution which is a national human rights institution and an equality body, meaning we receive complaints from citizens across various areas where they think their rights have been infringed. So we work on cases. We also suggest legislative amendments and do trainings and awareness raising and so on. So I've been working on cases of non-discrimination in the field of health for 12 years now. Also, as chair of Equinet, Equinet is the European network of equality bodies, brings together 48 such institutions across Europe, across the wider Council of Europe. And here we're coming together at the European level to look for commonalities. So, for instance, we not only are preparing a new publication on discrimination in the health sector this year in 2021, but also in 2020, we published a report on risks of AI discrimination, which is first such report looking at specifically the perspective of equality bodies as institutions which work on cases of discrimination. And also I'm a member of ECRI, the European Commission Against Racism and Intolerance, which you, Frederik, are aware of. ECRI's work has included also commissioning a report by Frederik, a report looking at AI-related discrimination. And finally, let me also say that I'm the co-representative of ECRI in CAHAI, and CAHAI is the Council of Europe's ad hoc committee on artificial intelligence, which just recently published a feasibility study, which was looking into whether a new legislative instrument, a new convention would be needed at the Council of Europe level to look at various risks posed by AI to human rights, but also to equality and non-discrimination.
Thank you. And could you remind audience members the difference between the Council of Europe and the EU?
Well, the Council of Europe has many more member states. It's much bigger. It includes all EU member states, but it goes much wider towards the east. So many more countries there included, all EU member states as well.
Thank you so much. So lots of non-discrimination law knowledge with Tena here. Thank you. Carlos, he's our computer scientist, professor of computer science based in Barcelona. And last year he was the chair, so kind of director, together with Mireille Hildebrand from Brussels University, of FACT, which is the world's leading conference on research into non-discrimination and fairness in the context of machine learning and artificial intelligence. I think you must unmute.
Indeed, I'm a computer scientist. Thanks for the introduction. I work on algorithmic fairness. That means I do research on algorithmic fairness, and I have also worked on algorithmic auditing, performing audits of decision support systems in the public sectors or a well-being mobile app in the private sector. So most of my experience is not in health. So I work in domains such as criminal recidivism prediction or university admission algorithms or search engines for jobs. Now, coming from that domain, I think there are very interesting questions that can be also brought to the health domain. So, for instance, if I may throw a provocation here, like in criminal recidivism, for instance, there is an author like Berg in 2013 who said, well, if the shoe size of a person in jail is a predictor of criminal recidivism statistically, then it should be used as for predicting whether this person will commit any crime in the future. And that is it's a very tricky proposition, because, for instance, we know that the risk of men of committing any crime for men is higher than for women. And more worryingly, we know that the risk of intrapenitentiary violence is higher for women who have been victims of sexual abuse in the past. So whether this feature should enter a prediction is a very complicated thing. And in the case of health, like suppose that the risk of rejecting a transplant is higher for people of African descent, then should they get less transplants because of that risk, because the statistical risk is higher? Like, these are very difficult questions. Now, in my field, some people usually answer those questions saying, we will do the best prediction possible, including shoe size, being a victim of sexual violence, and so on, all the features we can catch. And then some other part of the system downstream will take care of fairness issues. And I'm not sure that the way I would like things to be done, but that is the way sometimes in which computer scientists approach these kind of problems.
Thank you, Carlos. Super interesting. And worrying and thought-provoking example of the shoe size. Yeah, but first you move to Tamar. Tamar, anything about your background? Oh, by the way, Tamar is the director of the iHUB, an interdisciplinary institute, which also makes her my boss, basically, because I work at the iHUB. Tamar, what is your background and any first thoughts on the topic?
Yeah, well, I'm not Frederik's boss, first of all, but I do co-direct this interdisciplinary center that we're both at, where we're trying to bring people from different disciplines to look at how digitalization raises new challenges for society. So, of course, artificial intelligence and questions around discrimination are one of those. I myself am a philosopher of technology, so I've always been interested in the ethical and societal impacts of new technologies, especially in the health sector. I've always had a closer interest about health and medicine, and I've been doing that for many years. So I've followed a lot of technologies, from enhancement technologies to genetic testing technologies to mobile devices where that people use to track their health, to now artificial intelligence. And I think my background, or the specific interest I have here, is I've been seeing how the health and medical sector have begun in the past decade or so broadening out, because data that's generated outside of the traditional spaces of health and medicine has become relevant for inferring health information. And this has brought in new stakeholders like patients, but also like big companies like Google and Apple we're seeing. And these new technologies bring with them new or norms and skills and values which are not always the traditional ones of the health and medical sector, if we're talking about efficiency and cost reduction or speed and standardization. And there's a risk of crowding out, say, more domain-specific and traditional values and norms. And so I've always taken this approach of looking at how technologies put values that we use to make sense of our world and our lives under strain. So privacy has been one that has been discussed very much since we've begun realizing that digitalization also has harms and not only benefits. I'm very happy to see that this is broadening out to something like discrimination, but there are other values, of course, that are under strain. So I would like to push that even a little bit further to have more discussions around power and justice, maybe, than just discrimination and fairness.
Thank you so much, everybody, for your introduction. I know that you have several specialties, so I'm going to ask 2 questions that you each can react on. And if one of the questions you feel it's too far outside your own domain, please tell so, because only together we have knowledge, and each of us has different specialty. So one question is it actually useful to have this panel, or are the problems so much the same as in predictive policing and in job search engines that basically we should apply the same laws, and in computer science you just can apply the same solutions? Or is there anything specific about health that so should we continue with panels and papers, panels like this, or should we just discuss AI discrimination risks in general? That's question 1 that you can react on. And question 2 is non-discrimination law tends to focus, I think, Tena is the specialist, but non-discrimination law tends to focus on certain types of protected grounds, like skin color and gender, and shoe size is not a protected ground. Or whether you have blue eyes. So is there a gap in non-discrimination law in that field or not? And I'll just do the same order again. So Minna, first reaction? Unmuted?
I think it's useful to have health panels, but I think we can also think within the health field in a kind of comparative way, because it depends whether we are talking about AI in diagnostics, for instance. AI in pathology is, it's one thing, and it tends to raise different questions than, for instance, AI in healthcare resource allocation, where we might find question about, okay, are the most vulnerable people actually getting the best treatment? Or if we think about risk assessments, which are talked about a lot. So are we talking about diabetics risk assessments, and how those become part of healthcare practices? So all of these are already like very different domains when it comes to possible inequalities. And then when we've looked at these, we still need to think about what Tamar brought into the question, that how all of these different technologies are actually changing the logics of the health system. So are the questions that these technologies are addressing, do they originate from the health field? And that is one question that we ask in our group. Are these things being done because we have technology to do them? But do they actually help the healthcare system? So a lot of the risk assessments are based on, okay, we can do risk assessments. But then when you actually look at what they need in the healthcare system, it's not necessarily the type of risk assessment that can be done. So I think we need these kinds of panels to kind of pin down the questions that are actually relevant for the healthcare sector, and not be too focused on what the technologies are capable of doing.
Thank you. Fascinating. So sometimes there's a risk of solutions in search of a problem. Thank you. Then we'll just do the same order. Tena, any first thoughts?
Yes. So I'd say, is the health sector specific in relation to risks of AI discrimination? I think so. I would say, there are specifics to looking at non-discrimination in the health sector when you compare it to other grounds, such as employment or social services or any other specific area of life. And one of the main specifics of the health sector is, the extremeness of the consequences of life and health. So, a mistake can be fatal, and which is unlike many other areas. Another specific is the quality of data, and that's already it's already quite specific. There are specifics regarding the notion of fairness in the health sector compared to some other sectors. So in a way, also there's this I would even say a double black box when we speak about AI in the health sector, because as a patient, when you are approaching the health sector, usually we don't have the medical expertise. We're coming for different, fields of life and levels of education, and we rely on the medical professionals. We are sometimes in the dark as to what is really happening, and we rely on their expertise. And then you also add the AI part to it. So in a way, yes, I would say the patients are in a double black box. And I think the health sector is specific, the risks are higher, and there is the need for specific, I can see that I'm frozen, okay, sector-specific regulation is what I would advocate for. In terms of your second question and the specific characteristics, we, for instance, see already, even without AI in the picture at all, that there are currently certain challenges. You have different characteristics protected in different countries, in different national anti-discrimination legislation. There are some that will be present in many countries, like racial or ethnic origin, sex or gender, disability. But then there are some that exist in some national systems and not in others. So in some countries, you can claim discrimination in front of courts if you have been treated differently based on those characteristics. In other countries, you can't. For instance, health status is one particular ground which raises a lot of questions when you're looking at non-discrimination in the health sector. And it is only present as a protected characteristic in some countries. But another issue regarding characteristics, which is posed by AI, is normally in non-discrimination law in these cases, you have a certain ground and a certain behavior. And if you have differential treatment based on a certain characteristic, and you will have discrimination. However, with AI, there's the situation where you have proxies, which can be then connected to a particular ground. And that would lead to discrimination. But then you also have cases where a certain difference cannot be connected that easily to a particular protected characteristic. But still, it is a question of unfair treatment, of unfair differentiation, if you will. But does it amount to discrimination? Looking at current non-discrimination law, no, it does not. So there's quite a lot to be discussed, both regarding the health sector, discrimination in the health sector, both generally non-discrimination AI, but when you put the two together, it's a myriad of questions and quite a fascinating and fast developing topic. And therefore, I think this panel has, chosen a really, really good topic to discuss.
Thank you so much, Tena. Carlos, could you react? I also see that questions are streaming in now in writing, but I'll first do this round and then I'll introduce the audience questions and do another round among the panelists. Yes. Carlos, floor is yours.
So, okay, I don't know if this is an assertion that is shared by you, but I think that the media and the public in Europe has been perhaps more lenient with algorithmic harms or algorithmic threats, or less worried, because these threats have happened in environments that have vast power differentials and are somehow perceived as low rights environments, right? Like the policing of marginalized communities, the allocation of shelter for homeless people, criminal recidivism prediction, border control. And people say, well, I'm not a member of a marginalized community, nor homeless, not a criminal, not an immigrant, then it doesn't affect me. But suddenly we are talking about algorithmic threats in sectors where people, perhaps majority of Europeans, can interact, like banking, insurance, health, right? So I think they feel this. Perhaps the public will be more aware and more worried about these concerns, because these are concerns that maybe apply to them and not only to marginalized communities. Now, in the case of health, I think what Minna said, like, very clearly, like, what we want to look at is the impact of this technology on different groups, and in particular, if it leads to worse health outcomes for people who are the most vulnerable, right? And on that side, I would say that algorithmic fairness cannot be achieved in a so-called like color unaware or color blind manner, right? So first, because protected attributes are encoded everywhere. And second, because some groups need more protection. So these things are not symmetric, right? Another couple of things I will add to your question on whether why this is so important, I think it's to discuss in health, is because normally as a researcher or a developer, you ask yourself, why is this technology being introduced? And there is this book by Virginia Eubanks on automating inequality, where she concludes that in many cases the public sector introduces these technologies to reduce spending, and in this case, this no matter how I write my algorithm, it will lead to less spending in health, for instance, and this perhaps is something I don't want to create, right? Yeah, and one more thing I would say that it's Tena mentioned training data, right? Sometimes algorithmic bias comes from bad training data. Sometimes things are more subtle, right? So the decision is based on a number of features, and some of those features are protected, and it happens that the protected features are the most, for instance, have a very high correlation with the outcome, and so are picked by a system that is actually grasping at nothing, right? So there are very weak signals provided by individual features, and then suddenly it finds a signal like gender or skin color, and it latches to it, and it uses it way more. It gives it way more importance than what it should have, right? So it's not all the time faulty training data. Sometimes it is. Sometimes it is an algorithm that's just it is simply picking on among all the weak signals on some signals that happen to be protected.
Thank you very much, Carlos. So this is good. You have a computer scientist here who really understands the details. It needs a good warning. So the problem can be faulty training data, but can also lie somewhere else. Thank you, Tamar.
Yeah, it's really interesting to hear everybody's answers. So I'd like to pick on a few things that have been said. But for me, I think there are four basic points for me to this question. And the first one has already been picked up on, and that's that in the medical sector, the stakes are very high, right? So we're talking about people's lives. We're talking about increasing healthcare inequalities, but also people's lives. So a false positive or a false negative when it comes to automated decision-making in health can lead to somebody dying rather than being presented with the wrong advertisement. So there's something really different there. Yeah. And if we understand the underlying issues here as being maybe about power and existing inequalities, these are crucial in the medical sector because so many patients are already disempowered. And so the risk of further centralizing power could lead to greater harm. There's also, I think, sector-specific notions of fairness and justice that need to be teased out between the sectors. So for health, we can certainly say that there is an underlying understanding that access to healthcare should be based on need. And what we're seeing with a lot of the use of algorithms is that these are optimized for efficiency or they're optimized for cost reduction and not necessarily to recognize need and to increase access to healthcare. So that's maybe the first point about this sector specificness. Tena, you were talking about the quality of data, and Carlos, you mentioned it as well. I think that's interesting because well, bias is an inherent part of medical research. It's something that has been there for a long time. So you're starting out with flawed data, with incomplete data. We know that randomized clinical trials often don't include data on women and elderly people. Minorities are underrepresented in genomic data. And there's all kinds of studies now that show that women and people of color receive less pain medication or lower quality of care. That's there before we've even brought in the algorithms. So this is a very touchy situation. So, I mean, any machine learning model that's relying on these data, which start out as incomplete or flawed, of course, is going to replicate these biases, which are already pretty problematic. So there's a question there about, is this just continuity of the same, or is there something new? And I think we'll touch upon that some more as we continue in the discussion. Another point I think is that we can speak about algorithms in healthcare in relation to patients and how well they're represented or not. But there's also the question about what's the relationship with professionals, with medical professionals. And I think here too, there may be something specific to the healthcare sector, the medical sector, where accountability may be more of an issue here than in some other sectors, at least. And this may be because, again, the stakes are so high, but also because we expect a lot from doctors and clinicians. So they have expertise that we tend to hold in quite high esteem. So what does that mean when they're delegating some of that expertise to these technologies? Is this leading to a kind of de-skilling? I mean, we can think of the dilemmas we know about from self-driving cars, where we're saying, well, a human should always be in the loop or on top of the loop and be able to take over if the self-driving car makes a mistake. But there's a problem because, well, humans won't know how to drive so well if the self-driving cars are continuously driving. What does this mean in the medical sector, right? So is accountability different here? And I think it is. That may make things more difficult for medical professionals because they retain this accountability and liability and moral responsibility. It might make things a bit easier for them because if they're held responsible from the very beginning, we might see less de-skilling. And finally, a last point I would make, and this is a bit of a general one, I'm not sure if this is specific to health and medicine, but it's certainly clear here. Healthcare is a human practice that deals with humans who have complex stories and lives. Yeah, machines don't have the human skills that are quintessential in care: empathy, understanding, contextualization of information. But at the same time, the more that the only thing that counts is what can be translated into data, the more we'll be missing out on the patient experience and patient stories. So Epic's electronic health record, for example, doesn't have a rubric for doctors to fill in patient stories. So the connection between something like grief and fatigue, which are intermingled, need to be separated as two different symptoms of something. So this does something both to the professional, this idea of somehow a machine taking over, but also in terms of what can be recorded for the patients and how involved they are and what the patient experience is. And I think we need to keep that in mind also.
Thank you so much, everybody. I'm gonna try to multitask, which is always hard for me, and take some input from the written questions from the audience. Professor Berend writes, great to hear this emphasis on domain knowledge of the health sector. And Minna said, even within the medical sector, there are different subsectors or situations that call perhaps for different balancing and different reasoning. And could you say a bit more about that? A somewhat connected question is that somebody asks, how does this apply? How does all this apply to issues in the context of health humanitarian activities? So, for instance, when medics fly somewhere for a natural disaster, I imagine. And I can inform the audience that in our preparatory talks, we already put health insurance outside of scope because that would make things even more. Oh, and somebody asks, are there any red lines, like stuff that we should never allow AI to decide in the health sector? And we'll do a round again, and we start again with Minna. I think Minna has to unmute.
Yeah, so to deepen the different areas of health. So basically, if we're talking about diagnostics, there you would really have to think about the false positives, false negatives. So the accuracy is the key in diagnostics. So all of the kind of the questions that have to do with is like, you need to have good enough data to have accurate results. And of course, if you use machine learning, then it's not 100% accurate, but it can be more accurate than a human being, for instance, in pathology. So that creates kind of new kinds of practices around, how you think of diagnostics when the machine can do some aspects of the work better than the human can, but the human is still needed there. And also, you might end up in the situation where the machine is so accurate that you, for instance, start finding cancers or tumors that before would not have been any problem, because people just tend to have, those kinds of abnormalities. So the machine can be diagnostically so accurate that it kind of stretches the limit of what is healthy and what is not. So I think those are interesting questions. Then in terms of allocation of resources, there you are thinking about, okay, so where does the labor go? And that kind of allocation can also be machine aided. So you might think about, it's kind of like shift lists, but you think in terms of, what kind of patients you have. For instance, you could think of, for instance, in terms of rhythms of the healthcare facility. What kind of patients you get on Mondays? What kind of patients you get on Tuesdays? So you start thinking in terms of, okay, what kind of traces we have in the data about the kinds of people that come into this healthcare sector? And could we actually do the efficiency based on that? Because I think one of the things that I think is really, really problematic, that we actually believe when the tech developers say that it's going to bring efficiency. It's not said that it actually brings efficiency. One of the things that is not counted is the human labor that goes into implementing those systems. That costs quite a bit of money, but it's not seen as something. So in a way, I think that we can think about the efficiency also in terms of, for instance, allocation of work in a much more humane way. If we would, for instance, think about, okay, so on Mondays in Finland, we tend to get patients who have been drinking over the weekend. So then you kind of assign the care based on, what kind of people you get. Then if you think about the risk assessment, I think that's a bit tricky area, because there you basically get models that have already been used in other sectors, like we already heard from Carlos, that there's kind of this moving of risk models from sector to sector. So you have the true size in one sector, and then you bring the same model to healthcare sector. You have things like bad teeth, or you have things like mental health diagnostics in family, or you get things like postal code. So and then you put them together, and you might have like 1,200 different risk factors, and you don't necessarily know where do the correlations come from. So again, a very, very different kinds of questions in terms of what is just and what is not. So what I think is really important in this area is to dig deeper in these cases. And I think that ombudsman mechanism, for instance, is really excellent, because they have to really dig into the real life cases and see that what is actually going on here. Only then you start to see that, okay, is there something here that is just on a general level, like in the mechanism, or is it something that is unjust in the way that particular person is being treated by this system? And there's just so much to unpack here.
Thank you so much, Minna. Then we immediately move to Tena.
Yes, well, I was looking into what I could find on the use of AI in health in current practice. And it seems to me, when compared to some other fields of life, it's still rather limited. I mean, even if potential uses are exponentially growing according to the OECD 2020 report, still, if you look at it, there's maybe, I would say, 3 large groups within the health sector where you could look at the use of AI. And I think it's really interesting to connect it to the trade-off between benefits and risks. because it's not the same, or so it seems to me, for different parts of the health sector. So the first would be clinical settings. So really, for instance, for treatment of actual diseases. So for instance, diagnostic imaging to predict prognosis or response to treatment, data aggregation to predict consequences of surgical interventions, support the decision-making of most appropriate medical procedure to follow. And there, I would say, yes, the risks are rather high, and they seem to be, I would say, even the most dramatic. The second would be biomedical research. And there you can look at drug discovery, disease prediction and prevention, matching patients to clinical trials. And here I do want to mention something Tamar said, because the AI has the potential to address the documented problems of minorities being underrepresented in clinical trials. And here I would say the risk is slightly less. And here we come to the third bit, which I think is the least problematic, and that's the health system administration and management. And here we do have this focus on efficiency, I guess, with, you know, it can be identification of medical frauds by health providers, or automatic coding of diseases, and so on, scheduling of appointments, administrative authorization of requests for the delivery of medical services and products for patients. And here I would say the risks are really not as big. So that would not be a red area for me. I'm not sure I can identify a very strict red area among those three, but I would say number one is the highest risk. Number two, in my mind, would be slightly less. And number three would be the least problematic when you look at the trade-off between benefits and risks. And I think there are benefits, but there are also clear risks. And it's really important to think about them now, before AI gets used much more, and I'm sure it will in the medical sector.
Thank you so much, Tena. Good also that you point out, I think I forgot to say that in the introduction, this panel focuses on possible problems. That doesn't mean that we are against the use of AI in the health sector. It is just the choice of this panel to focus on risks rather than all the success stories and success possibilities that are there as well. Carlos, any thoughts?
Yes, I want to address the point about red lines, like, and where will I draw the red line? So I'll draw at least two. So one is systems that cannot be audited. So if there is a system for health where there is no data sheet describing the data, there is no reproducible description of the modeling process, and there is no like permanent ongoing access to data for research, then the system is a huge risk and cannot be deployed. One cannot deploy the system that is so opaque. So a system needs to be, you need to be able to audit such a system to deploy it. So that would be my first red line. And the second would be systems that are deployed and then forgotten for various reasons. So Minna spoke of a life cycle of an algorithm, right? And in reality, like a complex system has these algorithms that they evolve, they change, and even one piece of technology can have many algorithms in different versions that are being updated. So it's important to consider, not to forget a system that has been deployed. So there is a book by John Gall in 1977, which is called Systemantics. And he said, well, in a complex system, malfunction and even total non-function may be not detectable for long periods, if ever. And we have seen cases where machine malfunctions, or they simply don't function and nobody knows until very late. And I have to say, even computer professionals are afraid to touch models that have been developed by other people. Even we are afraid of doing that because they are very complex, and I rather kind of develop it from scratch. And I will not change it if I can avoid it, because they are very complex and delicate objects, right? So ideally, we want some regulation that doesn't discourage people from doing these updates, right? So if there is updating an algorithm, if people don't update their algorithms because they are going to have to jump again through a regulatory hoop, then that doesn't benefit anyone. So we want a regulatory framework in which people that doesn't discourage people from updating the algorithm, because updating the algorithm is completely necessary, right? So I would be completely against this idea of systems that are deployed and then forgotten, because they will not they will not function well.
That is fascinating. And what could scare away researchers or practitioners from auditing a system? Things like business secrets, or?
I think it could be something like, it's more for updating, right? So suppose I create this model for the skin, and then I have a version, like maybe next month or even in 2 months, I have a new model. Maybe I can have like 6 versions in a year. And I would like to be able to deploy these new versions, because maybe they fight bias, and I can react to a bias that I find very quickly. But in a framework in which that doesn't mean that I have to go to an entire heavy process just for doing this update. But there is like a process in which I update, and I also have like a control for what I call regressions, which are software that works worse than what it worked before. So as long as I can introduce these controls for avoiding regressions, and I can update frequently following a lightweight process for the updates, I will say, well, we have a system that is alive, and these things should have like a way of evolving, because as you discover things, they can be fixed, and as you discover more things, they can be fixed again, and this is a permanent process. The system is not just, it's never finished, in a sense.
Ah, this is fascinating. It reminds me a bit of for instance, phones that need constant security updates when new mistakes are found, etc. Tamar?
Yeah, I'd like to pick up also on the issue of red lines, and say sorry also to the person who had a question about humanitarian health. I really wouldn't know what to respond to that, and I realize nobody has picked up on it, but the red line question, I think, is a very interesting one to think about. I agree with Carlos that we should be thinking about red lines in terms of how we use these technologies and how we implement them, rather than say a red line which would be about which diseases these systems could be used to decide about or recommend, or what types of, if it's health allocation or if it's recognizing patterns. And I would say that, well, a lot of proponents of AI in health are really enthusiastic, again, about making healthcare more efficient. And there's this idea that artificial intelligence will do the more time-consuming and maybe the dirty work of humans, if that's identifying patterns in large data sets, which is kind of boring to do. From what I understand, you'd rather have a machine do it for you, or if it's, care bots feeding or cleaning demented patients. And then the idea is that somehow the human medical professional would be freed up to do what they're good at, those practices which are specifically human, like giving empathy and care and understanding. This dream is about as old as technology itself, that technologies will come and do the dirty work for us, and they'll just be our little servants. We know very well that in order to make that happen, we really need to be careful about how we implement these technologies and the type of work that goes into creating support systems around them and training people to use them properly. So this will never happen if we just kind of drop technologies in a system which is as complex as healthcare, or as complex an organization like a hospital. It won't happen on its own. And this costs money. So that goes against the whole cost reduction argument, right? It costs a lot of money to do this. The whole type of thing that Carlos is talking about, of the support that needs to be in place to regularly audit algorithms, to check what's going in, what's coming out, to monitor their downstream effects, to hunt for subtle discrimination, all of these things. It's a lot of work, and we should be aware of that before we start thinking that these things will just replace some of the more boring and time-laborious aspects of human work.
Thank you so much. Another question from the audience, very specific question, and I don't think on the medical device regulation, we don't have specialists on that, so I'm going to make, I'm sorry, question poser, I'm going to make your question a bit bigger and more general, namely, and Carlos hinted at already as one of the non-legal scholars here, but like, are there rules that should be adopted for AI systems in the health sectors? Are there legal rules? And the person who asked the question, he suggested in which regulation those rules should be put, but we can leave that aside. So is there anything that you think that the lawmaker should adopt now or should explore to regulate AI in the health sector? And I want to add another thing, and then you can pick one of the two questions to react on. Namely, I'm from the Netherlands, and the Netherlands is one of the more wealthy countries in Europe, and we have quite some heavy progressive taxing. But also in the Netherlands, there's a shocking difference between how old poorer people and richer people become. And the difference are not that big in Holland compared to many other countries. And even here, people who, poorer people basically die earlier. It is shocking. And we entered another financial crisis, so this may become worse. And we see in a lot of other sectors that automated decision-making tends to punish the poor, often by accident. But for instance, fraud detection in the welfare state, it tends to pick out poor people who are suspected of welfare fraud, and it does not tend to pick out white-collar crime where millions or billions are being hidden in tax havens, etc. And you see that from sector to sector to sector. I was wondering if you have any thoughts of whether that is relevant in the health sector too. So yeah, just pick your reaction. Carlos made a super interesting remark earlier that one of the things in the health sector is that the risks suddenly are also not for the groups, not only for minorities, but people who are not used to be the victim of discrimination suddenly run risk too. Anyways, I would love to hear your thoughts. And we still have, inform you by the way, 25 minutes, a bit less. We do the same order again. So Minna?
You had so many questions that I don't know if I remember.
No, just pick one.
What was the first question?
Whether the health sector runs the risk that economic inequalities are being worsened, or that people with less money run more risks than people with more money, or is in the health sector is it equalized?
I think in many countries we have already parallel health systems. At least in Finland, we have the public system, which is, basically open to all. But then if you're working, you get access to occupational health, which is faster and it treats you better. So you can have even with universal healthcare, you can have already these inequalities that are very well known. And how ADM and AI come into this picture is, I think, the fact that poor people are punished. It's obvious because a lot of these kinds of surveillance type of technologies, they are geared to people who need social assistance and social benefits, for instance. In Finland, there's a lot of push to bring health data and social services data together and build kind of models around, which can be a good thing in some ways, but in some ways that creates new opportunities for creating these kinds of surveillance models where you are kind of trying to identify the people who will be using child custody services, or who will be who are in the risk of mental health breakdowns or whatever. So and we all know that what is the kind of the leading cause of ill health? It's economic inequalities. So of course, we have this. If we have the economic inequalities to begin with, and then we have these health systems that have these inequalities. So I think, where does the ADM and AI bring?
Slow down with abbreviations.
Yeah. So where does the automated decision making come into picture here, and AI? And this I often wonder, because in some ways ADM is an old thing. In a way, it's bureaucracy. Bureaucracy is automated decision making in many ways. So there's a lot of continuity there, which is same old. People in countries like Finland are very used to government surveying them and making decisions for them. So there's a lot of continuities there. So then the risks there are same kinds of risks as, you know, has the government and bureaucracies treated people well before. So in a way, I find myself asking, what is the problem that ADM and AI are trying to solve? And then if we start like from kind of looking from there, that, okay, so what are they trying to solve? For instance, with the fraud detection. Fraud detection, if you start doing that, you already have changed the relationship to citizens. So you already think that citizens, you know, they're cheating you. That's kind of the basic idea, that we have these cheats among us and we have to find them. If you're talking about allocation of benefits, when you don't think of, you know, of in these terms, you are trying to build a system that is fair, that those people who don't know how to apply for these benefits would be better served. If you get the point what I'm saying, like this, a bit going all over the place, but I think that there's kind of these continuities, but there's also like kind of like, how do you see the citizen who is being served with this system, or is the citizen now being punished with the system?
Thank you. By the way, the Dutch government just fell because of a scandal of too enthusiastic fraud detection, which harmed poor people and probably also disproportionately people with an immigrant background. So it is a real problem in practice too, not only in academic circles. Tena.
I'll then try to connect to what Minna was saying. It seems to me that there are such huge differences across different countries in terms of public and private and how much the health sector has privatized. But there is, I think, something to be stated, that across the systems, there is this notion that economic inequality and the risks attached do connect also to other grounds of discrimination, for instance, racial or ethnic origin. So you would have something that we call, and I'm avoiding abbreviations and big words, but I will say it anyway, intersectionality. You will have an intersection of various characteristics, various grounds. So for instance, we see it when you look at life expectancy of Roma. You will have both this socioeconomic characteristic as well as this ethnic origin characteristic, which combine in such a way that what you see, it's very difficult to pull apart what exactly are the factors contributing to the fact that the life expectancy of Roma is so different than the majority population in European countries. But that's what we have, and we need to go back and unravel that and see what's happening, and not allow the use of AI in the health sector to contribute to that, but to reduce it. What I also wanted to go back to, but it's not only racial or ethnic origin, it's, for instance, you know, we already, without AI, and not even looking at the health sector, but generally currency, what we're seeing is who is really at risk of poverty the most. For instance, in my country, the research shows it's older women living in single households. So, you know, age is a factor, gender is a factor, but also living alone is a factor. And I'm sure health status comes into that as well. And so it is quite a complicated picture, because none of us are also can or should be reduced to only one of our characteristics. And there is quite an interesting interplay between those characteristics. But I do also want to go back to something Minna said in the last round. I don't think 5 hours would be enough for us to look at, to tease out all the answers and all these very interesting questions. But she did mention redress, and I think that's also something of key importance here. In the health sector, you already see that people are less likely to complain, to write, for instance, to ombudsman institutions or equality bodies, because of a myriad of factors. But one of them is this vulnerability. You are, as somebody whose health and life are threatened, in a psychologically vulnerable situation. And then you're thinking, you know, do I now complain against the system or the doctor or the hospital? you know, I'm really in need of their assistance. If I complain now, you know, who will be there to help me? And I really need help. It's different than, you know, being discriminated against in access to goods and services. In one store you feel discriminated against, you may as well go to another store. But the healthcare system is, well, you need it. But then also with AI, we also see difficulties with people knowing that they have been discriminated against. So in existing cases that, you know, when we look at the experiences of equality bodies, they don't get that many complaints, even in areas where AI has been used much more than in the health sector, because people simply don't know. Because you don't know that the outcome is discriminatory for you. You just, you know your own situation, you know of your symptoms, you know how you feel, you have your fears, and you don't know that, you know, there's actually discrimination taking place. And that really reduces the opportunity for redress, because you won't turn to the ombudsman institution, or you won't take a lawyer and sue somebody in a malpractice suit. And here I think it's crucially important to empower redress possibilities at the patient's end, but also to further strengthen and empower equality bodies, so ombudsman institutions and equality bodies, because they need also experts who are not only lawyers, because this is such a multidisciplinary field, and they need both more training, more capacity, and so on, but also certain legal avenues which many of our institutions still don't have. For instance, the possibility to bring forward a collective actio popularis case. So you know, the Erin Brockovich type cases to courts. Very few equality bodies can currently do that. And if you rely on the individuals seeking justice in front of courts, we won't get really far with AI. You need that sort of collective complaints and protection of collective interests. And I'll stop there.
Thank you so much. Yeah, we clearly have enough topics to discuss to do a whole conference on this theme, but in real life we only have 12 minutes left, so I'll quickly go to Carlos.
Yeah, so you mentioned, you made a remark about the broader, thinking of the broader context, right, including economic inequalities. We have here, like Minna mentioned, bureaucracies and the public sectors. And I have to say, I have seen with a lot of concern how algorithms are used in the public sector, right? Because of many factors that contribute to things not going the way we will expect them to go. So, for instance, we have overworked public workers that are perhaps quite detached emotionally from the concerns of their clients. We have people who either reject technology completely or see it as a magic bullet, and which leads to over-reliance or automation bias. But what I see with most concern is that there are huge incentives to avoid challenging the technological solution, right? So if in the case of recidivism, if the system says that this person is of high risk, but we believe that the person is low risk, then our job is threatened if the person commits a new crime in the future, right? And this is not theory, right? This is what I've seen in real systems being deployed, where the decision made by the system or the advice from the system is very rarely overruled by the human, right? So in the case of health, like the system may say that this patient should be kept in the hospital, but we believe the patient can be recovered at home. Like, what happens if we take that decision contradicting the system, right? Who is accountable? And we are training public sector people, and we're training public sector workers to follow the system, and the system may be wrong. And there is this worrying trend, I think, to abdicate the responsibility in the algorithm, right? And we have this human in the loop, but the human is not there. The human is worried that she may lose her job if she contradicts the system and things go wrong. But if she follows the system, then things will go okay, even if there is a mistake, right? And this is, to me, this is very concerning. Now, Tamar mentioned that the health sector has its own set of values and accountability, and there are certain values that are very strong in the health sector, and we should look at ways of introducing perhaps these technologies when they are needed and when they solve an actual problem, without contradicting those values, and helping to even increase the value of accountability and other values that are prevalent in that health sector, without pressuring them to be over reliant on technologies that are not completely wrong, but they make mistakes, and the human has to be awake to respond to those mistakes.
Thank you so much. Then household remark. We have 10 minutes left, so I'm going to give the floor to Tamar, and then I'm going to give last chance to the other panel members for one last and a brief remark. But first, Tamar.
Yeah. So about this kind of the general picture, and I think the risk of exacerbating existing socioeconomic inequalities, which is very big here, and it's I think the one that we're most worried about. I like to say again that this really has to do with the focus on increasing efficiency and reducing cost again. So if we think, for example, of an algorithm that helps doctors decide whether a patient should get back surgery, and studies will suggest that having strong social support is a factor that helps patients recover from back surgery at home rather than sending them to a physiotherapy institution, which is a rehab facility, which is also more costly. The algorithm can learn that people living in low-income neighborhoods on average receive less social support. And based on that data, if the algorithm is designed to maximize efficiency, which it tends to be, or even to lower medical costs, it's going to recommend against operating on patients from lower income neighborhoods. I mean, that's quite clear as to how that can work. And it's very worrisome, I think. And we're kind of horrified at this idea, I feel in Europe, like this would only happen in the United States, right? Where they have this healthcare system where you've got to pay to get into the system. We have universal healthcare. Of course, access is ensured for everybody. But we also, one of the cornerstones of precision and personalized medicine is to be able to predict which treatments will be effective for which patients. So we're very much in this logic as well, even with our universal access to healthcare. I think we need to be really, really careful of that. I think the point that Tena made about intersectionality is very important here too, because indeed what we're having with algorithms is these use of proxies, which turn out to be proxies for race or proxies for socioeconomic status. And so I'm not so sure how non-discrimination law works there, if that would be indirect discrimination, but it can be that this just gets lost. It would be indirect discrimination. Okay, so we have maybe some recourse to law, but I think a lot of what's happening in terms of predictive analytics, or what we're seeing, is that there are all kinds of data that are not, they're first of all not traditionally medical data that are being used in predictive analytics, and they're certainly not protected categories. So there's this booming market in the United States of these companies that do predictive analytics for hospitals, which would predict if a patient would benefit from a treatment, or if a patient would be expected to come back in after surgery, you know, what their chances are post-operation. And the types of data they're using are things like, do these people use public transportation? Do they pay back their loans? Do they have a car? What color is the car? This is really the insurance logic, right? So you get all of these proxies that I don't even think would count as non-direct discrimination, that are coming into making these predictions about patients and create categories, risk categories, like non-compliant, diabetes aware. So Linda Hogel, a medical sociologist, has done incredible work on this, and it's really scary. These companies exist. They're using this data. I don't know that non-discrimination law would help in these cases. And of course, this was picked up on as well. This makes things doubly opaque in a sense. So nobody really knows which data are being used to come to a decision. And that means that the professionals nor the patients have no recourse. They don't know what's happening. So they wouldn't even know that they're being discriminated against. The issue of recourse and redress is really important here, because opacity, what it does is it undermines accountability and taking responsibility for these decisions, and it undermines the possibility for redress.
Thank you, Tamar. Now I'm going to give you a really hard job, because you all can give a reaction of 1/3 of 5 minutes. And I'm going to make one remark. Somebody in the audience asked, what about AI in the humanitarian field? We didn't really answer to that, but I encourage you to look at the work of Dr. Lynette Taylor and her team on data justice. But now we're last remarks of Minna, Tena, and Carlos. Brief. Please.
Yeah. So what I think is really needed is some sort of public registry of what AI and ADM is being used in the public sector. And one of the things that we haven't really touched upon much, which is also a big problem, is that these public-private partnerships, we don't really know, how they will unfold. So there are a lot of companies that do experimentation around some technology and they are introduced in the public sector, and then they might just be dropped and something has already built around them, or they might go into a direction that wasn't initially intended. So we need more transparency when it comes to the technology that is used, but also what is actually happening. On a more positive note, I think that it's really, really interesting that we have new kinds of people talking about inequalities, and this is something that really energizes me and my work. I don't think ever before technology experts have talked so much about inequality. So that's a good start.
Thank you. Nice to have a positive spin at the end. Tena?
Yes, it's difficult to make it short, but I would say a multidisciplinary approach. I think we need medical practitioners. I think we need ethics boards in hospitals thinking about this, lawyers specialized in litigating medical cases, but not only lawyers as well. I mean, you need doctors and practitioners, of various specializations as well, because things can be different across specializations, but a lot of multidisciplinary discussions. I also think we need transparency, explainability, traceability, all those buzzwords which are there when you're speaking about AI, but especially when it comes to the health sector, because I've just looked now, the EU white paper does identify health as a high-risk sector to be regulated more strictly. And I think, this is something to have in mind. I think we do need human oversight. We cannot lose that. And I think we need to strengthen the enforcement and redress possibilities at the patient's end.
Thank you so much. Carlos, you have pretty much the last words of the panel.
Yeah, so discrimination may indeed be invisible to individuals. Tena mentioned this point, and I think it's a very important point, because when we audit an algorithm, we usually find subtle differences here and there and in the intersection of certain groups, and those differences are completely invisible for the people affected. Instead, you need access to a broad sample of people, both from majority and minority populations. And there are limits to what you can observe from an algorithm just from the outside, right? So there is very nice theory that says that sometimes it's impossible to distinguish a fair algorithm from an unfair algorithm just by looking at the outcomes. Right? You need an open box audit where you can see also inside there are limits to the observational metrics and to the observational measurements that you can make over an algorithm. So you need these requirements of, for instance, depositing the source code with an authority, creating reproducible builds that people can make sure that are from that source code, and provide ongoing access to data for public interest research. And you cannot just observe an algorithm and declare it fair from the outside. You need to look inside it.
Thank you, panel members. I learned a lot. I would like to do a whole see you next year at CPDP.
Thank you.
Bye.
Bye-bye, everyone.
Goodbye. Thanks for a great panel.